And I'd like to welcome everyone to our webinar today, The Evolution of COVID Testing, Treatment, and Management in an Under-Resourced U.S.-Mexico Border Community. We're going to be talking about lessons learned with far-reaching impacts for communities nationwide. We're going to go ahead and move on to the next slide. I do want to let you know that you can see the Spanish version of this presentation by going up to your screen where it says View Options. Just click on the down arrow, and there you can select if you want to see the Spanish or English PowerPoint presentation for this presentation. And then the same thing goes for your audio. If you want to listen in Spanish, simply click on the globe icon at the bottom of your screen and just select the language that you want to listen in. And if at any time during the presentation you are having issues, just shoot an IM over to Cari Gonzalez or Esther Rojas, and they will help you if you're having any difficulties. Moving on to the next slide. And just really quickly to let you know that this presentation has been approved for continuing education. MCN is an accredited provider of continuing nursing education through the American Nurses Credentialing Centers Commission on Accreditation. And then we have also submitted an application for continuing medical education with the Academy of Family Physicians. And so this presentation is accredited for 1 hour of both CME and CNE. And also, if you would like to receive a certificate of attendance, you must also submit the evaluation at the end of this presentation. And one more slide. I'm just going to read you our conflict of interest disclosure. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose products or services are related to pertinent therapeutic areas. And with that, I'm going to stop sharing, and Cari, you'll have to stop sharing as well. And I'm just simply going to hand it right over to our presenter, Del, and our presenter, Dr. Robert Johansson.
Roberto.
Roberto
Johansson.
Perdón, Roberto.
Sí, claro, que yo tengo el espíritu de mi madre dentro de mi corazón siempre y para siempre. Roberto.
Siempre, Roberto.
Right.
So,
Take it away, Del.
I'm going to take over just for moderating purposes. I'm so glad that you were willing to join us. You're in El Paso?
I am in El Paso.
Just so you know, I was born and raised there. Left a million
What high school?
Oh, this will make you laugh. Loretto Academy.
Yeah, then I just had, my wife is from Silao, Guanajuato. Her family was just up here. Guess where they went to high school?
Loretto Academy.
Yeah. Loretto Academy. So
Loretto
it's
Academy. That they were boarders. At any rate, let's
yes,
move
they were.
on. You still have the conflict of interest up in Spanish, or at least it is on my screen. I don't know if it is. Great, we're ready to go. Well, Roberto, my name is Eliana Garcia, and I'm the Chief Program Officer for International and Emerging Issues with MCN. And I've been working with the group in the education office in California forever and ever. And certainly, you know, we, like you, like a number of other people, have really been confronting COVID both personally and professionally for a while now. And I think that we speak to both, you know, the fatigue and the discouragement, as well as the enthusiasm now with the advent of the you know, the vaccines and everything else that's been going on. But I think what we really want to understand, just to set some background, is tell us about COVID in the early days on the border, as it was emerging and as you were starting to get a feel for what was going on.
Ay, Dios mío.
Yeah, well, there you go.
It to put things in
español, lo podemos hacer en español. Yo de acuerdo con que
I told they'll translate, and I do a bad job when because I'm a typical American. I have trouble switching.
Yeah, let's try to stick to English for our translators. For our translators,
yeah.
Marta just said English only.
But you know, when it first hit, you know, we don't have an academic medical center here on the border, and it is a friend of mine who's actually a provider in Juarez showed me data that showed that if you took 60 miles on either side of the Mexican-U.S. border and made it its own state, it would be the poorest in the United States, and it would be the poorest in Mexico. We also have the highest literacy rate, and so and I love the people I am privileged to care for. Here I go. I said I wasn't going to speak. It's their mi carencia. It's where the soul of my grandmother lives here. So it was rewarding, but we had to deal with a lot of medical ignorance, not really a lot of right information getting out, especially early on. We also had because of the border issues, we had some infiltration from, I'm going to call them what I see, white supremacist groups, 3%ers, the Proud Boys, and they actually spread in some disinformation. I was running an outpatient COVID clinic trying to get people tested for isolation, and we needed to hire security to sort of put it into, and we were also combating our ignorance about the virus, but also about people willing to politicize it. Does that answer your question?
Well, and so, I mean, really what you're saying is more than the virus itself, it was the politics and the environment around it that were the largest challenges. Is that correct?
Absolutely. And, I mean, like I said, I feel so privileged to work where I do and with whom I did. And I was actually a little surprised to find people were objecting to help supplying that care. I had the opportunity to work with the migrants and the migrant workers. And yes, I'm named after my uncle, Roberto Lefebvre, who was the migrant worker lawyer. And he wasn't a güerito, he was trigueño. And they remind me of that. And so you get that powerful, privileged feeling that you're in the right place, helping an incredible group of people. And then other times it would be, this, you're putting RFID chips in people.
Mhm.
This is made from killed children. This was a lab release. And, I also had people, we were vaccinating when the vaccine did come out. We were going to the bridge and, people were crossing the bridge to come get vaccinated. We worked with Las Americas and also an incredible organization here called Annunciation House. And we were vaccinating migrants. And interestingly enough, when we were testing the migrants, they had a lower positive rate than the non-migrant population. So and so again, early on, it was really scary because, we had 195 patients die in our little group. And again, mainly elderly, but, there was a woman who had just delivered her baby, 37 years old, had a 9-year-old. And so I got upset when I would hear the news or read something that talked about this being made up. It's not really there. They're still giving Dr. Ferguson a hard time for predicting a 3.4% fatality rate. And we're not that far off. And to be quite honest, I'm actually was friends with a guy named Robert Malone. We run some boards together, who point blank told me he makes more money doing antiviral work than he did as a surgeon and immunologist. So that's another element that I'm sorry, 30 pieces of silver.
Yeah. And so, I mean, you talked about the political pieces and that they were difficult to confront. Do you feel like you overcame them? And what were you feel? I love the smile. Do you feel like you overcame them? And then what were some of the strategies that you felt really worked for you?
Well, first off, to kill my Latino pride, you'll have to kill me. Because I always tell people, yo tengo el espíritu de mi madre, mi abuelita, dentro de mi corazón, siempre para siempre. And I say that with pride because I work with some incredible young people, 18 to 24 years old. And they came to work knowing they were getting threatened. They came to work knowing they weren't going to get paid. They came to work knowing that, they went out to the fields with me. Okay. They crossed into Juarez with me. So, and these are just some incredible, so I had that energy. And fortunately, the one of the places I work is in FQHC, and the medical director here, Juan Loya, is an incredible. He supported us 1,000%, and he actually came and worked with us. And there were people would come up and tell me, "Well, Bert, I know your suegra," and well, you're from El Paso, television, Telemexican. So right. It became, oh, doctor, you're really skinny. And next thing I know, there would be pozole or menudo.
Hey.
And so you're asking me, and I know this sounds a little silly, but I realized that I was in a family.
Yes.
And I realized that family was strong. Mm-hmm. And that's what kept me going, and it kept the team I worked with going. And fortunately, we got to a place fairly early on when we had the infusion, the monoclonal antibody infusion. So I was able to go to these people who really were desperate and sick and say, "Hey, I got a treatment for you now."
Yeah. I think, but you really hit the nail on the head from what we learned as well, which is it was all about trusted messages, people that you could really feel were being honest. They wouldn't steer you wrong. They had every reason to want to take care of you. And that's, over time, we kept hearing that over and over again, and we heard it at the border and we heard it further up. Do you have colleagues that work into the interior of the U.S.?
Yes, I do. And because I always tell people I really don't live in Texas because, as you know, El Paso we're more Mexico, New Mexico than the rest of Texas. But I do have colleagues that were in San Antonio and in Houston. And I was able to get, and I also have colleagues, thanks to the NMHA and also my prior service in Washington, D.C. So I was able to get new information, sometimes medication, and when patients needed to be airlifted. So, there's some incredible people who we came together as a community, which leads me to my next point. As Latinos and Latinas, we made up 8.2% of the healthcare population, dentists, doctors, nurses, pharmacists. Now we're down to about 5.8. And people ask me, is it important? Absolutely. Because able to pick up the phone and I was calling an NMHA member, picking up the phone and I was calling somebody that I was in LMSA with. That connection, which we call goladilla, was really important. But also understanding, again, you're from El Paso. I'm in Segundo Barrio. I don't want to leave home.
Yeah.
And being able to bring that together, culture is important.
Yeah. And so, I think I would believe it that the experience of COVID on the border was really different in many, many ways than the experience of COVID in the interior because of not so much the insularity of those communities, but the connectivity in those communities, which I think is what you're speaking to. And so as we've now progressed and we have the vaccine, what do you see going on around COVID among the people in your community?
Well, again, my community consists of migrant workers, and also some of the most incredible people God put on the planet. And I just read a paper that said you're more likely to get the vaccine if you're Democratic, college educated, make over $90,000. Well, my community is, if they were citizens and could vote, they'd probably be Democrats. They don't make anywhere near 90,000, probably much less than 25,000. And none of them, a great many of them, they went to Bowie, La Bowie, right?
La Bowie, sure.
La Bowie, c'est claro. And, but yet they lined up for the vaccine. I mean, they were out the door, around the street, and in the same thing when we did the migrant workers, they would, mira, te vuelvo loco, venga, because they knew we were bringing vaccines. So it was a very different experience. So that when literature came out, and again, I don't mean to get political, but that you're more likely to be unvaccinated and get COVID if in counties that most likely went for the former president than our current president. And that says a lot. That speaks to the disinformation. And right now what's happening with the new vaccine, I'm having patients wanting flu, they want the RSV, and they want Nuevo COVID.
Yay!
And I know the football player, Kelsey, is getting grief for it, but a lot of my patients heard them on television and they're pumped.
And so now that it's moving to the primary care setting and it's moving away from the hospital, I mean, what do you think? Do you feel, somewhat, I mean, the folks who were certainly very ill will wind up. How do you think it's going to get managed? Is it going to get managed like the flu, or what do you think?
Well, I have some mixed concerns about saying like the flu, because as you may know that I did a great deal of work on influenza. And everyone says, don't worry, it's just the flu. Flu in a non-pandemic year kills 50 to 100,000 people in the United States. And granted, it tends to be the older. Well, I don't know about you. I loved my abuelita and I love my suegra. So to hear it say, well, it just kills old people, I don't like to hear. That's also untrue. People forget that influenza can also cause a myocarditis, a rhabdomyolysis. It can cause long-term chronic illness. The movie Awakenings was about people who had been infected with the 1918 influenza and went into what is known as vancomycin encephalopathy until they later discovered the dopamine. So there are these other issues like long-term COVID. So as it does move into primary care and less so hospital and ICU, I'm still concerned that we're going to get into the attitude it's just the flu. They're both killers.
And so what is it going to mean then for primary care to try and manage something that can be so, complicated and difficult to try and get your hands around in a primary care setting?
Well, I'm caring for a patient right now, literally just before here. She's
can I interrupt really quick?
Absolutely.
Just a message from our translators, if you could speak a little slower, that'd be great.
Okay, yeah, it's a good thing I'm not speaking Spanish because I speak Spanish even faster.
Yeah, our interpreters, yes, thank you,
I
doctor.
lo siento. Okay, please call me Bert. So she's 65 years old. She's a cancer survivor, and on rheumatoid arthritis. So she's vulnerable. And the interference, I had to call her HR manager to get her to come get tested and to work her up. And I may admit her just simply because she is ill. She's one of those people where the vaccine probably doesn't help her because she's on steroids and hydroxychloroquine. And so I think you're right. There's going to be levels of complication for certain patient groups that we still need to be aware of. The second level of complication is there is a vaccine fear. Great many patients refuse the influenza vaccine. I suspect there's still going to be a continued refusal for COVID vaccine. And again, as an intensivist, I've seen RSV kill the very young and the very old. And I would love to see a trifecta, a vaccine containing those 3 viruses. And you get 1 injection and you're safe. So yeah, I agree with you that I think there's going to be multiple levels of complication. We need to really talk to our patients. And I like what you just said. You need to sit down, look our patients in the eye and say, don't worry, madre, this will help you. I got accused of grandstanding when I got my vaccines on television.
I got all 3. I got COVID, flu, and RSV.
Yeah,
Okay.
sí, claro.
So,
And the reason I did it is because when I walked back into Segundo Barrio, and they pointed their arms. So for the people that I was concerned about reaching, we did.
yeah, I think that is always that story of it is through those personal connections and that we move on. And so what we know across the country is that there are any number of clinicians with that same kind of relationship with their patients. Our founding medical director, our current chief medical officer, always talked about their patients and the patients whose babies they birthed and all of those things and the depth of that relationship. And so I really do think that, the federally funded health centers, the primary care settings are going to be a critical element in all of this.
Mm-hmm.
But I don't know that they see themselves that way.
I would agree with you. I don't want to get myself in trouble, but I'm not really well liked by a lot of CEOs in this town, particularly because I firmly believe that our patients need to come first and not money. You grew up in El Paso. The 2 largest healthcare providers are HCA and Tenet, and the people running the safety net hospitals are former HCA, so they're running it for profit. And that deeply concerns me because I don't know. We got to take care of people. We got to make sure that no matter what happens, I want to be able to look my patients in the eye and say, "Don't worry, no preocupe, señora. You're going to get the care you need."
Mm-hmm.
And frankly, I don't know if I can do that anymore.
So we got moving on COVID because it was a public health emergency. Flu has never been considered really a public health emergency in people's presentation of it. So what's going to be the better strategy for us to look at things as public health emergencies, or to really try and say, look, we just need to be conscious of what's in our environment?
The answer is yes. I think COVID was more of a health emergency because we didn't know. And I know a lot of people who are against the things that you and I do and support. Well, you changed your mind. Well, that's because we learned about the virus.
Mm-hmm.
Didn't know. Just like in 1918, they didn't even know what a virus was. So back in 2009, when there was a vaccine mismatch with influenza and the H1N1 spread, those of us over 30 at the time were okay. And they didn't declare an emergency because we knew about the biology of this virus. We were able to make a quick vaccine. So to answer your question, I feel comfortable moving COVID into that category because we do have a vaccine. We do have treatments. And I think also we're better about detecting it. I'm not a real fan of the rapid test, but then again, I'm not a fan of the rapid influenza or the rapid strep test. Yes, I still use the Cerner criteria. And I think as we move forward with it, as we become more knowledgeable, and we do things like this, where we can have the information spread through our groups. I feel comfortable. I can't believe I'm about to say it, treating it like we do influenza.
So then what do we do with the next pandemic, with everything that you experience? And I believe
Well,
that there will be another.
I absolutely believe there's going to be another pandemic. We know, Jesuit high school, Catholic education,
My brother.
tú eres mi hermana, ¿verdad? And the reason I bring that up is because they made us learn Roman history, Greco-Roman history. And we know there are things like the Thucydides syndrome, which most likely influenza. We know there were outbreaks of the Black Death, which we've come under some control. And actually affects disease now. We had HIV, which again, these plagues. I think we will have another emergence of an infectious disease, which we know very little about. Right now we have Nipah virus in India. We also have some other interesting causes of death. So I think we'll have other ones. And I think we should take what we learned in COVID, that there will be some people who are going to refuse to believe and refuse to get help. And there will be people who will say, please help me. What can you do for me? And I'm actually of the belief that you say no to either of them. If you don't say no, you care for all of them. And, I currently have 2 patients in the hospital who refused the vaccine. They treated themselves with alternative medicines, and they're still my patients. I disagree with them politically. I disagree with the choices they made medically, but I will do whatever I can to care for them.
And so what are they allowing you to do now?
I'm giving them remdesivir. Their oxygens are low, so they're getting dexamethasone, and a lot of support. I mean, they're on. I'm a real fan of high flow oxygen, and then I will go to BiPAP before I intubate. But I don't think either of them are going to get intubated. But they're on high flow oxygen and still satting about 90, 91.
And so do you think that there will be a change of heart in either one of those 2 people?
I think the Bible tells us something interesting about this guy Noah,
Mm-hmm.
who invited people to get on this boat. And some people have said, no, go screw yourself. And there will always be those people who won't believe, who don't want. And again, we need to take care of them. But when there comes a point when the water rises that unfortunately, we will lose people who won't change their mind to the very end. And that saddens me.
So we've talked about, sort of what went wrong and what you needed to overcome, and then what went right in terms of speaking to people. Were there other things that you felt were done well? Were there materials that came out? Were there presentations that were done well? What was done well?
What was done well, number one, again, NMHA was able to get pamphlets translated into Border Apuche Spanish for me, which is different. I also got them translated into Raramuri.
Wow.
I know, and then the other advantage was right over here at Sacred Heart Church. Father Garcia, Rafael Garcia, and I are long-term friends. So he actually spoke from the pulpit about care, and we set up a vaccination station just outside the church. So we use what I consider very Latino ways of getting the message out.
And do you see that those are elements in the community that will continue to rise to these occasions? We saw many religious individuals not choose to support what was going on, and they seem to be a really critical element of the work that we needed to do.
I agree with you. I'm Roman Catholic, so I'm going to stick to what I know. I grew up in the leftist group. My grandmother. I was raised Dorothy Day theology, the Catholic worker. My grandmother and all my tias and my mom were Catholic workers, a follower of Dorothy Day and Peter Maturin. But as you know, there's also the Thomas More Society far to the right. So I don't think we can come out and say this religion. But again, here in Socorro Barrio, as you know, people still go to Nachitas and get pozole. And it was really, to me, the most appropriate way to address it. I also went to Bowie and gave a talk in the big auditorium. And yes, I think there were some people who didn't believe, but I think in terms of getting the message to the right people, it was the right way. And I think understanding who we are as Hispanics, I don't know about you, this macho stuff that people try to push on us. Mi abuelita ran the family, okay? What she said went. And I think that was very important. And I have to tell you, I think I fell into that. I realized that when I was going to places to talk and when I was handing out pamphlets, I'm like, oh, cool, mi abuela. You know? And I think we need to continue to do that in our community.
And so, what do you see then in terms of broader care for communities? Because you said, you know, you're starting to feel like you're not going to be able to do it. Where is it going?
Well, hopefully I'll get re-energized, but I really do think we need to be practice equity and equality. We need to address, the African American community. People forget that, our African American brothers and sisters were subjugated to things like the Tuskegee, but they also forget about Sims, who experimented on enslaved women for gynecological. I recently gave a talk here at Burrell, the new osteopath school, about no mas bebes. The Mexican American women were essentially forced to take the birth control pill. It also happened in Puerto Rico. And under the Buck versus Bell 1927 Supreme Court decision, where an Irish woman who spoke only Gaelic was labeled as an imbecile, she was forced sterilized. It went to the Supreme Court, who said yes. And when people say, hey, that was 1927, Britney Spears was held under conservatorship using Buck versus Bell.
Wow.
So where I'm headed is we got to recognize that there are these beliefs based on some reality in our communities, African American, Asian, Hispanic, what I call ethnic Irish, ethnic white, Irish, Jewish, Polish, that we need to address. That we need to say, I understand your culture suffered. I understand this happened. And again, you said it earlier, trust.
Mm-hmm. And so, we look at young people coming into medicine now, and so much of what they are taught, and many of the places where they are trained, are hospitals. Part of me worries that the soul sort of gets taught out of them. What is your sense of clinical care for the future, and where are we going, and what do we need to be doing?
I'm glad you asked that question, because I have a deep concern. I'm a firm believer in ACEs, adverse childhood experiences, and I think our caring and compassion for medicine has been beaten out of us, because you need to see 40 patients a day. You can't spend time talking about it. How do you feel? How do you do? Also, there's been some interesting articles, one recently in a journal called The Pharos, about the decay of the academic health center, where, I think about the mentors that I had. I met a woman years ago, Dr. Megan Lawrence. She was the first African-American, first female to be admitted into the pediatric program at Columbia. She retired at the age of 90. She just passed away in 2020 at 105. And I loved being around. She taught me to sit on the floor. She taught me to play with my patients. I moved here to El Paso. I got written up and had to take a drug test because of how I treat my patients. So I think we need to continue to stand up. We need to continue to fight. And again, I think we need to teach our young residents, our young medical students, our young nurses, our young pharmacists, patients come first. Compassion and care are part of that. We cannot just be robots.
My mom was a nurse in her younger life and got written up, as you say, for getting in the shower with an older Mexican gentleman because he could only have tub baths. They would only let him sit, and he wanted a shower. And they were discovered because they were sitting in the shower, or they were standing in the shower singing old rancheras. So here you go, that what you do for your patients. And so as you look at El Paso, what do you see going on there? And do you feel like El Paso is like the rest of the border, or will continue to stand?
I think El Paso, the answer to that question is yes and no. I used to tell my wife when I was working at UMC Children's Hospital that I left El Paso every day when I went to work. And I actually got called a racist for this, but none of my colleagues were Latino. They were immigrants from the Indian subcontinent, and again, I'm descended from immigrants, so I don't want to get down on them, but they didn't speak Spanish. They would say, I've never seen the father. Well, the father is a migrant worker, so he can't always come in. I had a patient, again, she was in our hospital for almost 2 years. The father couldn't cross. I'm sorry, I almost, La Migra wouldn't give, La Migra wouldn't give him a LASA visa. And again, they should, working here, understand that element of our culture. And then the yes part is now when I come to my clinic here in Segundo Barrio, I'm connected to the rest of the border. I'm connected with Juarez. This past weekend, family from my wife's family from Guanajuato was visiting. We went to Arturo's in Juarez.
Mm-hmm.
And so there's so the answer to your question is yes, it's a bit of both, and it depends where you are.
And I guess feel like the border will always be different from the interior.
Thank God.
Okay.
This my only regret is I didn't move to El Paso 30 years ago. And my wife sits there and goes, claro. Por supuesto.
Yeah.
And it really, again, I have my problems. I think medicine here needs to be better. I think there are a lot of things that are lacking here, but what's not lacking is the incredible people that call themselves El Pasoans.
Yeah. And so do you see clinicians wanting to come to El Paso to work, or is it still having
They want to come here because they
recruiting?
think they can make a lot of money.
Mhm.
I am seeing a few people are coming back, because they want to help with the community. And the unfortunate problem with one of the places, they don't stay here very long.
Mhm.
The turnover rate's very high. But yeah, we do have a core that are coming here. They're practicing good medicine and they care about it. And but I think for the most part, there's a lot of people come here on J1 exceptions, or they're looking for an HB1, and as soon as they get that visa, they're gone. But for the most part, there is a core of really cool, mostly young people. Unfortunately, of the residents and medical students who I've been the advisor to, none have come back.
Mm. I know will sound like a silly question, but do you think COVID was good or bad for medicine?
I think it was both. I think it was good because it revealed, and again, this is coming from my intensivist thinking, where we made mistakes, where we needed to learn. Also to rely on, hey, look, we have these technologies that can save people. And it was bad because I think now we have a greater level of mistrust and distrust. And we didn't handle, I'm horrible in the media. Because it comes out of here, it comes out of here. And and I think we didn't manage our image well enough. And I'm going to give a specific example. You would watch the news, whether it's Fox or CNN, and the person they were interviewing was an assistant professor in the ER.
Mm-hmm.
Why weren't you interviewing a professor in infectious disease, or a professor in epidemiology, or a professor in virology? So there was a lot of young people out there, and I got nothing against young people. I was young once, last century, and who really, I think, could have been more forceful. And also, again, addressing the communities we mentioned, a little gray hair goes a long way.
Absolutely. Yes, the Migrant Clinicians Network has for years and years worked in the area of infectious disease, particularly tuberculosis. And I do know, that both our founding medical director and our chief medical officer are TB consultants or TB clinicians in their states. And there's always, our founding medical director, Ed Zerwesta, has always held that, when we find that there's a case and we treat it successfully and we go out and we do all of the surrounding case investigation, that should be honored. That should be, when there's a fire. And he went to a meeting once and was trying to tell that
Oh, we lost Del for a second. I'm going to give her a second to see if she comes back.
Yeah. I live along the border. I'm used to losing telephone service.
All right. Well, while we wait for Del to come back, I'm going to go ahead and field a couple of questions that came into the chat. Dr. Burt, if you're okay with that.
Let's do that, please. And when she comes on, just stop me.
Sorry, Del, we lost you for a second, so I'm fielding some questions.
Please do, because I was busy talking to myself, having a big old time.
I do that all the time.
Thank you.
It was great. I was telling a wonderful story. We'll have to get. Go ahead.
All right. Here's our first question. And I guess either one of you can answer this. what is the current feedback regarding the newer COVID vaccines, flu vaccines, etc.? Have you seen vaccine exhaustion, quote unquote, where people are just tired of hearing or needing new vaccines?
I'm seeing some of that, but I also have patients lining up wanting the vaccines. So I'm seeing both.
And one of the things that we see, we do a lot of work with the Ventanilla de Salud. Bert, I don't know if you're familiar with them. They're inside the Mexican consulates.
Yeah.
And we've had a lovely, lovely relationship with the Austin Department of Public Health, and they bring the shingles vaccine, which is enormously expensive, and they use it up. Whatever the amount that they bring, we have enough elders who are interested in having that done. And again, I think it is, you're in a safe environment with people you know want good for you, who are offering something critical to your well-being. Am I disappearing again?
No, we heard you, Del. Thank you. We're going to have another question. This one I'm going to turn over to my colleague Cari. This question was asked in Spanish, so she will go ahead and ask.
Hola, buenos días.
Buenos días, ¿cómo está?
Bien, bien, gracias. Y yo estoy cerca de Silao, como a 30 minutos.
Sí.
Sí. La pregunta es, si las personas migrantes que pasaron por un centro de detención del CBP fueron vacunadas o no, si se tiene conocimiento si las personas migrantes en centros como de Caridades Católicas en McAllen u otros, si las personas fueron requeridas para que se vacunaran.
El doctor desapareció, ¿verdad, Cari?
Sí, no sé si se salió del...
I think he might have left. I can answer some of that for you.
Please do, Del.
Because I do know that very early on, CBP was saying to us that there were so many people coming through and they were moving them through at such speed that they were not able to vaccinate them. And for a long period, and there was a great deal of concern around this, they were not testing either. They were just bringing people in. What I do know is a lot of the shelters who were along the border had the vaccine available to them, and they were not requiring that people be vaccinated. Rather, they were letting them know that it was available to them so that if they wanted to be vaccinated as they were getting on the road, they would be able to do that. We went and had a visit with Casalitas in Arizona, and they were doing an excellent job of speaking to everyone who was coming through, but it was very clear that it was completely voluntary. Are there any other questions, Marta?
Yes, there's quite a few questions.
Bert's back.
Welcome back, Bert.
Well, he can't hear us. His audio is connected.
Oh, that's right.
Oh, there he is. There he is. Not.
I'm gonna ask one more question because I feel like this is an interesting question. It's coming from Guillermo. How to deal with the legislative prohibition for using DSHS funding to promote or create specific campaigns about COVID? Any thoughts on that?
Again, I'm working with the Hispanic Dental Association as well as NMHA, and we're putting out good information, countering disinformation, participating in lots of programs such as this one, but also getting flyers out and going out and talking in person to counter that. I'm a bit upset that we're sometimes restricted in doing that because we need to counter and it saves lives. But to quote my favorite movie, a baby's got to do what a baby's got to do. Rugrats.
Yes, and Bert, while you were gone and coming back, I was looking at some of the questions. And Cari, this is in Spanish, and I'm sorry to be jumping the gun, but there was a question about what you thought about the treatment with Paxlovid.
I always tell people, and I tell patients, the medicina es muy amargo, and it's stronger in Spanish because sour. Because having taken the pill, it's very bitter, sour, and it stays in your mouth for a long time. So I believe it's helped save lives. And because I've seen people turn around very quickly in a day or two, including my suegra who got COVID during the middle of her treatment for breast cancer. And I think dealing with, I tell patients point blank that it will give you a little diarrhea, making you not feel that well. And I've talked to my patients about what to take along with it, like peanut butter or chocolate milk to help make the flavor go away. I'm hoping we come up with some other medicines, and unfortunately, we had the ivermectin, the hydroxychloroquine, and I think hopefully we'll come with some other less expensive, easier to use meds. Because again, it is the people kind of laugh, but the flavor really does interrupt therapy.
And so do you feel like that Paxlovid is well managed in a primary care setting? I mean, our focus really is to try and be concerned with folks in health centers, because, you can get to an ER, you can speak to somebody there, but, where's that line between how sick someone needs to be when they come to the health center and they stay within the health center, and then when they have to move off into a hospital setting?
Oh, that's a great question. It's one of the biggest problems I have. I'm recently getting some surgery myself. A 46-year-old bone graft failed in my mouth from injuries I received in the Army. And I bring that up because there was an outbreak in the little pod that I go get my care. And the doctor in charge of the pod says, well, I wasn't sick enough to take Paxlovid. And it's something that I'm hearing, and I try to explain to people. Paxlovid is when you're still mildly symptomatic or asymptomatic. Remdesivir, which it works, so but there's this belief that you only take Paxlovid if you're already sick. It's too late. And we've done those studies. So I think that's that piece of misinformation we need to get out, because to answer your question, it should be done in primary care. It keeps people out of the hospital and keeps people from ending up in the ICU and keeps people from dying. More importantly, we've also seen that both in adolescent groups and older groups, it cuts down on the long-term COVID.
And so are you seeing among your peers a real understanding that that's the course of care?
No, I mean, I was getting some bone maturation protein put into my mouth, and I was listening, and indeed this individual came in and said, well, I wasn't sick enough for Paxlovid. And,
so that needs to be, I guess, one of the areas of concern for us if we're trying to do education, to really talk about the value and the use of Paxlovid. I mean, there are not that many chases, so we ought to be better at this. I think one of the pieces that we would also be concerned with is, what else do we need to be saying to primary care providers?
Past, don't be afraid to treat, be aware of comorbidities, and be aware of the long-term problems, which include hypertension, include the brain fog. I cared for an individual who was a charge nurse, and his memory shot, and it's been 2.5 years. I haven't been able to clear him to go back to work. And I've known this man for 13 years. It's not the same guy.
Wow. And that is part of our work that we need to be about, is that we need to be preparing. And I think that this becomes a particularly difficult question if a majority of your patients are migrants that you will not be having an ongoing relationship with. And so then your interventions then, what do you say? What do you do?
Well, I get phone calls from all over the country, because for patients that I'm very worried about, I give them my phone number. And I'm, even if I was very happy when they were going to New York, because that's where my connections are. I mean, if they ended up in a Tyson's plant somewhere in Mississippi, essentially lost. And so there's a huge concern. And one of the things we did is we printed out a medical sheet in Spanish and English that had all the things that they should do it, and they could hand it to a primary care worker or someone. But unfortunately, a great many of them are lost to follow-up. And the same thing's true with my migrant workers. They lost to follow-up.
Bert, Migrant Clinicians Network has a program that's 29 years old called Health Network that does acute care management. You could enroll these people with us.
Send me the information.
Try and help you keep track of them so that they could stay in care.
Send me the information, because I need it. I haven't delivered a baby since medical school. I've delivered 2 since this has happened. And
wow.
I managed to get their early vaccines, but I am worried about the continuing care. So please send me that information.
Okay.
Again, part of the lack of an academic health center down here really impinges on some of the stuff I can do. But everybody is interested in. You grew up here,
really
Yeah.
want to see people get from where they are and where they've been identified to where they want to go and stay in. So we've been doing this a long, long time. And I think that we could be a benefit to you as well.
Oh, please, because there's a number of kids who I have with diabetes, some with thyroid illness that need ongoing medication.
Okay, we'll make sure that gets to you. Martha, I cut you off and I'm not sure that I let you finish the round of questions you concerned with.
I have one more question. Excuse me. Go ahead, Dr. Burt.
A nurse just gave me, I need to go see a patient very quickly. So I will be back in a couple of minutes.
Yes, thank you.
Yeah.
That's fine. Thank you.
Bye.
Here's one for you, Del.
All right, let me hear it, Martha.
Does COVID affect management of chronic diseases such as diabetes?
Yes.
That was great.
Yes, and I think that everything needs to be looked at really carefully when there is a chronic disease, because that is lifelong. And something like diabetes that affects your immune system is one of those places where you want to make sure that the person is attending to both what they're struggling with in the immediate, like the COVID and what may have some ongoing pieces, but they are also attentive to the fact that their diabetes will affect how well they can do, and they want to make sure that they're taking care of themselves. And I think I have another friend who is also a physician in a hospital and who had, did stints in the ER. And he said during the entire COVID piece, we stopped seeing people who came in for anything else, and they had hypertension or they had a cardiac problem or whatever, and they stopped coming in. And his fear was that everything else that was going on in the person's lives that might be chronic, that might be lifelong, was being set aside out of this tremendous and not falsely placed or wrongly placed fear. And so it is really trying to look at the person in their totality and trying to remind ourselves that it's everything about us that keeps us the healthiest that we can be. And the healthiest we can be if we have diabetes is that we have well-managed diabetes so that everything else we confront then can be managed well also.
Yes, I agree, Del. Thank you.
What should we do since Dr. Burt has gone off to take care of patients? Are there any other questions that are?
There are several questions. Actually, this group has put in quite a few questions. Here's a question about monoclonal infusion. I don't know what you have to say about that, Del.
I have very little information on it. I do know that there's been some controversy, but certainly we would want to hear from a physician on that. I don't know if Ed or Laz are on, or if there's another physician who would like to weigh in, and I would hope that they would do so.
Yeah, Dr. Zoroaster is actually on. Ed, I don't know if you want to chime in on that.
Does he have the capacity to unmute? You need to make him a speaker, Martha.
Yeah, let me see if I can unmute him here.
Because I think if we have questions that are really connected to clinical care, then we need to make sure that they're addressed by a clinician. Ed, can we press you into service?
Can you hear me?
We certainly can.
Loud and clear.
All right. Sorry. Monoclonal antibodies were used a lot in the beginning. They went into disfavor after other better treatments became available. And I still think that is about what's happening with monoclonal antibodies. As far as I know, we have better treatment now. But again, that's a better question for Dr. Burt and or Laz, who are doing it day to day. Since I'm not doing it day to day, I wouldn't want to be the only answer to that particular question. But my understanding is there are now better treatments than we had. That's what we had initially, because that's all we had.
That makes sense. Thank you, Ed. Kari, I don't know if there are any questions that have come in Spanish that you would want to ask.
Yes. ¿Cómo ha ido avanzando el tratamiento para el COVID desde el principio de la pandemia hasta hoy en la actualidad? ¿Se ha logrado evitar complicaciones severas dando algún tratamiento médico? Esta pregunta es de Cristina Rivas.
And you can answer that in English in terms of advances that have been made in treatment, particularly those that allow us to cut off the possibility of severe outcomes.
So I think as Dr. Burt mentioned, now we have good antiviral medications, and the use of oxygen, high flow oxygen early on, has prevented a lot of people from having to be intubated in the hospitals. So there's a lot more that we can do initially, and also the use of steroids in hospitalized patients. So we're able to save many more people now than we were initially. And again, that's evolving as we move forward because we're getting more studies all the time of how this virus acts and how we can treat people. But again, I want to go back to the most important thing is prevention by a vaccine. We have a very safe vaccine, and the new version is out, which is even better than what we had with the bivalent because it's very specific to the current Omicron mutation that is circulating right now. So vaccination is way before treatment.
Thank you, Ed. And I saw a question in the chat, Del, that asked about the new vaccine and if you know if it's going to be available for free in the El Paso area.
You know, there was a response earlier on by Mariana. You know, it ought to be free under the Bridge Access Program of the CDC. And if you'll scroll up to about 12:36 in time on the time marker, you'll see Mariana Eberl is the way I can see her name. I don't get to see all of it, but there's a link there for the CDC, the vaccine program, the Bridge Access Program for the vaccine. I do know that often what was done with the vaccine is that city and state health departments also made the decision that they would make sure the vaccines were free. So I would believe that in many communities, there are going to be options available to people. And it would be really great if those of us who worked in that sector would make an effort to understand what the resources were in our communities. But I would look at the Bridge Access website.
And if I could just add to that, Del, yes, it's state by state. For example, in Pennsylvania, the State Department of Health will give it free to anyone who is not insured or underinsured. And the community health centers will also have it available for people so that no one should have to spend $100 for this vaccine. There's those three options: community health centers, your local health departments, and the Bridge program through the CDC.
We've just been talking about whether or not the new vaccine was going to be available for free, and we had one of the participants give us Ed was talking about the fact that it's going to be state by state, and what they decide to do, and where they're going to be local health departments or state health departments. And the CDC has a project called Bridge Access, which will also be talking about low cost. But I think that there, as was previously the case, going to be options where people have to at least investigate what's available in their communities. As I said, the Ventanillas de Salud worked very hard. The Hispanic construction workers in Texas helped us make sure that we had vaccine available through the Ventanilla. And so I do believe that there will be a number of resources, but it does require that everybody, take some time to see what might be out there. There was Martha, can you restate the question that we had originally?
We had a question come in about monoclonal infusion, and I was wondering if you had any thoughts on that, Dr. Burt.
Yeah, I do. And let me one more thing though. Yes, the FQHC I work at is not going to offer the vaccine because they can't get it for free. So I've done some investigating, and through Las Americas, I have found places that are going to be able to give the vaccine to my patients. One of them is called Immunize El Paso. So you're absolutely right. We got to come up with some creative ways. Now, the monoclonal antibody, I think was a wonderful thing. It was the first time I was able to tell patients I have a treatment. And I don't think it's going to play a big role in the outpatient setting anymore because we do have oral chemotherapeutics. I have been reading the literature in that it may be useful on inpatient, that, you know, that the people, there is a subset of patients we know that have high viral counts, high viral loads, which is why they're so sick, and that the monoclonal antibody reduces that. So there may be another role for that. So I'm glad the person asked, because I don't think they should be counted out yet.
But there are good oral treatments, as you said. And so
Yeah.
I think your statement about Paxlovid as an option early with consideration, as opposed to waiting until someone is really quite sick, is an important message, you know? Marta, anything else? Riccardi, anything else?
Nothing for right now. I'm going to go ahead and share my screen so you guys can have the link to the evaluation. If you don't mind, Gadi, if you can put it on your screen as well.
So I have a quick story to tell you. The patient I just went to go see, the nurses were saying, you know, your doctor's really famous. He's on they're being interviewed by a famous group.
There you go.
Thank you.
You got to make
Thank
that
you for adding to
point.
my.
Okay, so
But it goes to the trust issue, and again, it's something that we need to consider.
Thank you, doctor. So I do have the evaluation QR code up for those of you who wish to receive a certificate of continuing education or a certificate of attendance. And while I have this up, if you guys could give us any last thoughts or opinions on COVID at the border at this moment in time.
I'm hoping we don't have a repeat of early. You know, we ran out of ICU beds. We only have 46 beds in El Paso, and we were putting patients in, converting rooms to ICUs. We had a shortage of respirators, and we had, you know, if we have to ship out for ECMO. I'm really hoping we don't have to relive those days because of the vaccine and because of oral, you know, Paxlovid. The additional thing is, now that we do have a basis, again, either by infection or vaccination, and we know that even with the changes that are in the two current strains, that we may not see is a higher rate of infection or higher rate of hospitalization and ICU admission. So I'm sitting here with bated breath with my fingers crossed.
Doing multiple crossings. And I think what was when I think about COVID at the border, and one of the things that I got to see at a number of places from San Diego down to Harlingen was that action by the community to try and step up, and not only for their own little side of the border, but looking across the border and understanding that relatives lived and worked on both sides, and that really what was good here was essential there as well, and that efforts were made to try and link those two pieces. And I think that that's what is always going to make the border so precious, in my estimation.
I believe you. I love that.
You know, so yeah, I think that there's nothing like what we saw in terms of, you know, care being, people walking across the bridge from both sides, and vaccinations being delivered at the apex, and then people turning around and walking back down. So I'm really grateful to you, Bert. This was a great conversation. I really enjoyed it so much. Thank you for taking the time to talk to me. And I'm hoping that, you know, we'll be able to press you into service to be a colleague with us on a number of other things. And we'll make sure you get the information about Health Network, because we don't want you to ever be afraid that you're going to lose one of your patients.
And I have to honestly tell you that I had a young man who had abdominal leukemia. And I'm not scared to admit I went to church, and I lit candles. And I got a call from him about 2 weeks ago. He's living in Nueva York, and he's alive. And so, and I'm sorry. But yeah, Yeah, thank you.
Well, we can certainly count on divine intervention, and then we can also help.
Yeah,
Right?
well, yeah, and it just, so thank you. And if you ever meet my wife, she will tell you that I stay up night and worry and read and do all sorts of things. And because I love being a doctor, I love knowing that I can help other people. And and I also love the fact that what my family gave up for me to be here. I'm proud of being an immigrant. So your words bring great. I love them. I just thank you so much. Oh,
This
sorry.
was a delight. All right, you go
And
back
with
and
that, I would like to thank everyone for joining us today. Just a
Oh.
reminder, you will be getting a follow-up email from me later on that will have links to the recordings, both English and Spanish, as well as the links to the evaluation in English and Spanish. And Dr. Burt, thank you so much. I can't thank you enough. Del, thank you so much. Ed, thank you for chiming in with your comment. And I'd like to give also a big thanks to our interpreters. I know what you do is incredibly hard, so thank you so much for that. And with that, I will leave you all. Have a great rest of your day. And please remember to turn in those evaluations. Have a good day, everyone.
Gracias,
you.
mi hermano y mi hermanos. Vaya con Dios.
Gracias.
ciao, ciao.